Thank you, René. Christoph, I hope you get your train. It's an honor to be here. Thank you very much, Chairman. TAVI, as you all know, is an established treatment options for patients with aortic stenosis, especially in high-risk patients. But we all know, and Christoph also pointed out, that more than 200,000 patients are being operated worldwide with a surgical treatment, and most of these patients will get or still get bioprosthesis. So patients will have degenerative bioprosthetic valves in the future, and we know that this is also age dependent. So younger patients, for instance, a 50-year-old who gets a bioprosthetic valve will have a risk of redo surgery in almost 50%. So this is also an issue which, of course, TAVI valve-in-valve will be on the scope in the future for these patients. But first, what is important for a valve-in-valve? Of course, there are three things. First, patient selection. We have to know if there's an endocarditis, this is a no-go. If there is a concomitant paravalvular leaks, this is not a patient for valve-in-valve. Then we have to know exactly the valve. So what type of valve is this? And then we have to actually measure the inner diameter. We have to know exactly what the inner diameter is to pick the appropriate size of the new valve. So here are a few options how these valves look like. A pannus. This is a good case for valve-in-valve. The thrombus is a bad case for valve-in-valve. Calcification, of course, is very good. Wear and tear of this valve is a good option for TAVI, valve-in-valve, and endocarditis, of course, is a no-go. We have to know what valve we're dealing with, which valve is degenerative. And there are 4 types of valves, as we know: the stented supraannular position, the stented with externally mounted leaflets, and of course the stentless valves. And these valves also have different features of markers in the fluoroscopy. So we can always actually look at the chest X-ray and actually make a guess of what type of valve this is. So if we have something like that with markers in the crown, then we know this is a Medtronic mosaic valve. If we have markers in the crown and in the sewing ring, then we know it's a Hancock valve and so forth. So actually, after a while, you get used to these valves, to these features, and you know exactly what valve you're dealing with. Important is how the dimensions are of the stented prosthesis, of course. We need to know the inner diameter of the stent because that defines the size of the valve we're implanting. This is different in the stentless bioprosthesis. So stentless xenografts, the labeled size is always the outer diameter of this graft. In a homograft, the labeled size is the inside diameter of this valve. So this is a little confusing. And therefore, there's also charts available, and I can show you a more sophisticated chart. This is from Edwards. It's actually, I think it's also online. And we have for all sizes and all type of valves the appropriate inner diameter available. So we know exactly, if we know the valve, of course, how much room there is for the new valve to put in. If we don't know the valve, or if we don't know the size, we can always size with CT. So for instance, oh, excuse me, this is the wrong button. For instance, if we have a Medtronic mosaic, size 23, we can size also with a CT, and we get not exactly the same as you've seen. This is 20.5, what we have from this table. We measured 19.5 in this CT scan. In fluoroscopy, it always looks a little different. It's not like in CT fluoroscopy. There are components of the bioprosthesis which are not radiopaque. So this is an issue if we have, for instance, a Sorin mitral flow valve. which has an acetylate stent, which is not radiopaque, but that stent defines the inner diameter. So if we have a valve put in and we see something like that, there is a gap between the valve prosthesis and the marker, then we know there's something which is not radiopaque. So this is something we have to know, and that's why CT scanning is always better in valves we don't know. CT scans, I think, is recommended in all patients which are coming for TAVI, valve-in-valve, also for deciding or defining the stent posts in the prosthesis, if they are lying exactly next to the ostium or not. We have to know exactly where they lie, because when we put in a new valve, we can actually never foresee, what the stent post does. But if we know that they're not lying in front of the ostia, we're well off. So this is something we have to know exactly. Then for sizing, there are manufacturer sizing charts. For instance, here, this is the Medtronic sizing charts. If we have an Edwards valve with a 21 size labeled valve inside, we know it's a 19 millimeter diameter, inner diameter, and they actually just give you the correct valve, which they think is the appropriate valve. So this is going to be a 23 core valve in this Edwards SAV 21 millimeter. So this is available for all valves, but we have to be sure and we have to be aware of small valves, because small valves are always a problem, because we know from experience that a 19 millimeter Carpentier Edwards has an extrinsic gradient which is higher than in bigger valves. So this is a 19 valve, has a mean gradient of 35 and has been referred to TAVI. So we have to think, is this a good patient? Can we help him? If we're going to put in a new valve, are we going to reduce this gradient? This is the question we have to ask ourselves. This is a problem. So the 19 millimeter valves and the 21 millimeter valves are a problem, and we have to be really careful about treating patients valve-in-valve in these small valves, which is not impossible, but we have to be aware of the problems. Therefore, there are also more size options available. We have a 23 core valve now, and a Sapien 20 is also on the way. If we have a small valves, valve positioning is really very important, because in all these different valves, the leaflet levels are different from each other, and the markers are, of course, also different. So this is a mosaic valve. The leaflet level is here, so we have to be very careful about valve positioning, and we have to know the valve, and we have to exactly position the new valve in the appropriate position for getting a good result. And we know, this is a table from John Webb, we know that device malposition is common, and especially in stentless valves. So stentless valves are a problem for positioning the new valve. And we've seen, or he has seen, that almost 15% of these patients, they experienced a malposition of the device. Also, is there a risk for coronary obstruction? And we can say, yes, there is a risk of coronary obstruction, especially in patients with stentless valves. Obviously, in this registry, I'm going to show you later a few slides also, in the global registry, the stentless valves experienced more coronary occlusions than non-stentless valves, non-stented valves. Especially the Sorin has been shown to be a little problematic for a valve-in-valve. So we can say stentless valves experience a higher risk for coronary obstructions in valve-in-valve. But is a stented valve then safer? Is it easier to implant a stented valve? Because we might think, the stents are robust and stiff, so they're not going to move, which is usually the case, but not always. So there are few valves, especially the thorin, mitral flow, and the trifecta, which are actually built in a same or in a similar fashion with the outer pericardium on a very soft stent. So these valves can pose a problem for coronary obstructions, and there are a few patients we've seen with the thorin freedom I showed you, and with the thorin mitral flow in these patients where the stent was exactly lying in front of a coronary ostium, which is not a good idea, of course, but the stent is so soft that the posts got exactly in front of the ostium and caused this problem of coronary obstruction. So to show and to find and wrap up with my talk, this is the Global Valve-in-Valve Registry for TAVI by Danny Dwyer. He presented that in 2002 at the EuroPCR. It's a global registry of all patients done or registered, at least 45 sites. And he had shown that TAVI valve-in-valve is a safe procedure. The outcome data are more or less the same as in regular TAVIs, so 8.4% death after 30 days. So actually more or less the same as for regular TAVI, so we can say it's a safe procedure. They actually compared then the Medtronic to the Edwards valve if they found any difference, and actually in these patients, especially in small annulus, which has been defined by the inner diameter, of course, and has been in less than 20 millimeters in 20%, they showed a difference in gradients. So they can show, or they showed that the transvalvular gradient was higher in SAPIEN compared to the Medtronic core valve. And he concluded that in smaller valves, in the smaller 22 or less than 22, a core valve has a superior gradient and a superior functionality compared to the Edwards valve, which is the reason because the valve lies, the leaflet lies above the other valve. So therefore, the opening of the core valve or of the osteo orifice is higher or greater than in the Edwards valves, which has been shown in this chart. So he has shown patients, these are patients with 20 millimeters mercury post-procedure. In 43%, they showed a higher gradient than more than 20 millimeters in the SAPIEN, and only 24 in the core valve in smaller than 20 millimeter annuli. And in larger annuli or in larger valves, there was no difference anymore. So in summary, valve-in-valve is a safe and effective procedure. Of concern are the valve positioning. So there is a valve malpositioning problem. Sometimes coronary ostia can be occluded, and the high gradient, especially in small valves, is present. And they recommend for smaller valves, less than 22 core valve, and for 22 and higher, we can use both valves. And if we have more questions, it's always like everywhere. There's an app. There's an app for valve-in-valve. We can download it, and it's actually made by Vinny Papat. He gives it away for free. We can download it, and they give recommendations what valve to put in, what position is recommended, and so forth. So thank you very much for your attention.
Thank you.